Hello and welcome to the latest edition of the Cancer Research Institute's Immunotherapy and You Patient Education webinar series. I'm your host Ajit Mulay, Assistant Director of Scientific Content at the Cancer Research Institute in New York City. Today we are talking about cancer immunotherapy advances in lung cancer. We will be discussing a variety of topics related to cancer immunotherapy and lung cancer. We will also discuss the unique advantages of immunotherapy and the ongoing new research in the field of immunotherapy for lung cancer. It is my pleasure to introduce our esteemed guest today, Dr. Thomas Marron. Dr. Marron is Director of Early Phase Trial Unit and Associate Director, Cancer Clinical Trial Office at Tisch Cancer Center at Icahn School of Medicine at Mount Sinai in New York City. He is also Associate Professor of Medicine, Hematology and Oncology, and Associate Professor of Immunology and Immunotherapy at Icahn School of Medicine at Mount Sinai. Welcome, Dr. Marron. It's a pleasure to have you with us today. And I'd like to start by asking you the topic about lung cancer. And we often hear that lung cancer is one of the most deadliest diseases. So can you just share with us what makes it the deadliest? Why is it so feared?
So lung cancer is one of the most common cancers in both men and women. And unfortunately, despite many advances, especially the novel immunotherapies that are included in the treatment of most lung cancer patients, most patients will go on to die from their illness. And there's really two reasons. One is the majority of patients are unfortunately diagnosed when the cancer is already metastasized or spread to other parts of their body. And at that point, we're left with very few curative options, although we are now curing some incurable cancer with immunotherapy. But ideally, we would catch lung cancer and all cancers for that matter very early on. And, recently there's been very strong data from our institution and other institutions that's demonstrated the utility of screening for lung cancer, and it's specifically only for smoking-related lung cancer at this point. And it's in smokers and people who have a history of smoking who should be getting CAT scans to low-dose CAT scans. So it's a low dose of radiation, but getting that every year in order to look for early signs of lung cancer. Because if we catch cancer, any sort of cancer at stage 1, it's much easier to cure it than if it's already progressed to metastatic disease. But unfortunately, even though it's a recommendation of the USPSTF and most medical organizations, both in the United States and abroad, to do this sort of screening, most patients aren't actually getting the screening the way that people get mammograms and colonoscopies. So unfortunately, most of the patients that I end up meeting, the cancer has already spread, and we don't have as many options to cure them as we do if we catch it very early on and we can start thinking about surgery and potentially radiation.
So what are the factors that might increase our risk to have lung cancer?
So there's many different factors that we don't know about and some that we do know about. The most obvious one is smoking. So smoking is the number one cause of lung cancer in the United States and worldwide, and it remains that even though smoking rates are going down. There's still a lot of smokers in the world, and unfortunately, even in patients that have quit smoking, they still have a very high risk of getting lung cancer and other cancers because of the damage that the smoking has already done to the DNA throughout their body. And so it's in those patients where the best thing that we can do is really be screening them for lung cancer. Other reasons why patients get lung cancer, one is radon. That's actually the second most common related cause of lung cancer. And I think most people, when they buy a house these days, you check for radon in the basement, and that's obviously one step forward into decreasing the exposure risk. But there's also about a third of patients that have cancer that's really not related to smoking. This is a population that's actually growing while the population of smokers is shrinking. And those are patients that immunotherapy is not so helpful for. In those patients, we tend to use targeted therapies. But the majority of patients still have smoking-related lung cancer. And even in non-smokers that don't have targetable mutations, immunotherapy has really revolutionized the way in which we treat them.
Is there any way we can reduce these risks, like not smoking at all? But are there any other precautions that we can take to prevent lung cancer?
Quitting smoking is the number one. And quitting smoking is not only important for the smoker, but it's also important for their family around them, because the ambient smoke can cause cancer related to secondhand smoke. And so it's a really important thing to do. And that's, number 1, 2, 3, and 4 on the ways to prevent lung cancer is smoking cessation as globally as we can do it.
What are the options that we have for treating lung cancer?
So there's 5 ways in which we treat lung cancer. Early stage lung cancer, we can occasionally use either surgery or radiation to remove cancer or to burn cancer with the radiation. And then for cancer that has spread, we have 3 different systemic options, which means medicines that go throughout your body. So if it has spread, these medicines get to everywhere in your body that the cancer is gone. The first and the oldest therapy we have is chemotherapy, and that's still really a cornerstone of the way in which we treat lung cancer and many other cancers. We also have targeted therapies, and these are specifically for patients who have mutations often that are associated with lung cancer in patients that have never smoked in the past. And then we have immunotherapy. And immunotherapy is an FDA-approved approach, but it's also an umbrella term for lots of different medicines that use the immune system to recognize and attack the cancer. So we have immunotherapies that target 3 different sort of pathways within the immune system right now that are all FDA approved and that we're using in cancer patients. But we're also developing thousands of additional immunotherapies. And once again, they are all slightly different approaches because they all use the immune system in a slightly different way to recognize and attack cancer.
Is the therapy that you're talking about, chemotherapy or immunotherapy, do the therapy regimes differ compared to patient or cancer type to cancer type?
Yeah, so there's 2 main types of lung cancer, and they're called non-small cell lung cancer and small cell lung cancer. And these are very different types of cancer that come from a very different sort of subset of cells within the lung. Small cell lung cancer is a cancer that is treated primarily with chemotherapy and radiation if it's caught early on. Or more commonly, since it's already spread, we use a combination of chemotherapy and immunotherapy. And the addition to immunotherapy really only came in the last few years and is now omnipresent. Everyone gets chemotherapy and immunotherapy, which significantly improved how long people live with small cell lung cancer. And there's even a small subset of patients with small cell lung cancer that respond really well to immunotherapy, and we think that they actually are able to achieve a durable remission. While in the past, small cell lung cancer was a uniformly fatal diagnosis. Unfortunately, even with the addition of immunotherapy, patients still typically will eventually succumb to this disease. So we still have a lot of work to do in small cell lung cancer to better harness the immune system to recognize and attack the cancer. The more common type of lung cancer is non-small cell lung cancer. And this is probably around 85% of lung cancers that are diagnosed. And we subdivide that into 2 different types of non-small cell lung cancer. About a third of patients have what we call squamous lung carcinoma, and the other 2/3 of patients have a lung adenocarcinoma. And this is really just a way for us to identify where the cancer is coming from within the lung and identify what the optimal therapies are, because we do slightly different therapeutic approaches based on if it's a lung adenocarcinoma or a squamous cell carcinoma. All of those patients, though, the adenocarcinoma and the squamous cell, if they do not have a very specific mutation in their DNA that we have a medication to target, they are going to receive immunotherapy if they are found to have metastatic disease. Or now, even based on data from 2023 and 2022, we're now also using immunotherapy in patients who have stage 2 and stage 3 disease because we know it improves outcomes.
I see that immunotherapy is coming out in big way to treating different type of cancers. Can you just tell our audience what immunotherapy is, like for a layman who doesn't know what immunotherapy is? What it is?
So the term immunotherapy is really an umbrella term for anything that activates your immune system to recognize and attack cancer. And there are specific types of immunotherapy that are already FDA approved and oftentimes advertised on television, so many people have heard of them. But there are actually right now thousands of immunotherapies that are in development. The Cancer Research Institute actually puts out a report every year which highlights just how much development is happening year after year. And the immune system in your body is there to tell the difference between foreign things like COVID and normal things like your lung. And your cancer is somewhere in between. Because cancer is not quite as foreign looking as COVID, but it doesn't look anything like the lung that you were born with. So it is foreign to your body. So theoretically, your immune system should recognize it as something foreign and attack it. But what happens is that cancer puts up lots of stop signs, and it basically turns off the immune system so that even if the immune system is sitting there chomping at the bit to attack the cancer, it gets turned off. It becomes what we call exhausted. That's actually the term that we use for the immune cells that are not doing their job. So immunotherapy is all about really tearing down those stop signs. And while we have drugs that target 3 of those stop signs that are FDA approved right now, we actually know from our work in the laboratory and looking at human samples that there are dozens, if not potentially even 100 or more ways in which cancer hijacks the immune system and turns the immune system off. And that's where a lot of the progress is going. But right now, most patients will receive at least one immune therapy that targets an axis called PD-1 or PDL1. And that really is a stop sign. PDL1 is a stop sign that many patients' cancer will put up and say, don't attack me. And those therapies are all about tearing down that stop sign so that your immune system does its job.
We know that many of the cancer therapies, whether it is radiation therapy or it is chemotherapy, they come with their own side effects. So have you seen there are side effects to immunotherapy as well?
So it's a good question, and it is very different from chemotherapy in particular, and also radiation. So radiation and chemotherapy have a very predictable time course for side effects. We know if patients are going to lose their hair, when it'll probably happen. We know that patients who receive radiation to their chest might have a sore throat after X number of weeks. Immunotherapy is very different because the majority of patients don't have any side effects. But a decent chunk, probably 30 to 40% of patients will have some side effects. And the reason is that these drugs are really revving up their immune system. And if your immune system gets a little too revved up, hopefully it's attacking the cancer, but sometimes it also attacks normal parts of your body and causes inflammation elsewhere in the body. So the only common side effect that we really see is rash. And I would say that we probably see that in somewhere between 10 to 15% of our patients. And that's caused by the immunotherapy activating the immune system and the immune system causing inflammation in the skin. It's also the easiest side effect for us to treat in most patients because we can use steroid creams just to turn the immune system back off. Occasionally, it's a little bit more complex to treat, but it is something that we see very often. But immunotherapy can cause inflammation anywhere in the body, and most of the side effects are very rare, but it can cause inflammation anywhere from your head to your toes. And the most important thing is that when patients are on immunotherapy, whether it's as standard of care outside of the context of a clinical trial, or particularly if they're on a clinical trial of a new immune therapy, the most important thing is to communicate early and often with your doctor. Because let's say you had immunotherapy causing inflammation in the intestines that would lead to stomach pain and diarrhea. If we hear about that after 2 to 3 days, it's much easier to treat in most patients than if you come in and you tell me, oh, I've been having diarrhea for 3 weeks. Because at that point, oftentimes patients are much more sick and we have to admit them to the hospital and turn their immune system on using IV medications. So it's tough though, because everybody has a different experience. And like I said, most patients have no side effects, and the side effects are very difficult to predict. Sometimes, I have seen patients have side effects as early as, 2 to 3 days on treatment. It's very rare. More commonly, patients might have side effects anywhere from 6 to 10 weeks after starting therapy. But that said, I had a patient once that was on an immunotherapy, and 18 months after starting, he developed a side effect. So it's just important for people to communicate with their doctors and let their doctors know any change in how they're feeling, even if it's a good change. Give you one example. I had a patient who came in and he had just finished a clinical trial, and we think he is cured of cancer. And he gave me a big hug, and he was moving back to India. He gave me a big hug and he said, "Thank you for curing my cancer and my blood pressure." And that was a little alarming because immunotherapy should not treat blood pressure. And it turned out he had a side effect where he had inflammation in his brain that controlled the cortisol level, which is the adrenaline level in your body. And so because he flagged this before he moved back to India, we were able to treat his side effects, and he's alive and well many years later now. But it's one reason why, as doctors, we always have to ask all the questions under the sun, but also we always warn patients that any change in how they feel, even if it's a good change, like not having to take your blood pressure medicine anymore, it's something that you really have to flag for your doctor and make sure, allow them, those specialists, to make the decision if this is something to worry about or not.
So coming to patients and the caretakers, do they have to prepare in advance for going through immunotherapy, and what kind of preparations you would ask them to do?
Good question. So unlike chemotherapy, where we sometimes will have to start some medications, a week or at least a few days beforehand to avoid side effects, that's not the case with immunotherapy. So there's no specific preparation that's needed. What I do tell people, going back to our discussion about side effects, is to be doing a really in-depth sort of self-assessment head to toe. And both the patient should do this and also their family members should do this, because sometimes patients won't notice that there's something going on. You might not notice a rash on your back, for instance, but their loved loved ones will. And so I think that it's important from, the day one that you're starting immunotherapy to do a daily check-in with yourself, and even a check-in looking at the mirror, just to make sure that you know how you look, how you feel, so that if there are any changes, you can identify those early and hopefully treat them much earlier and much more easily than we have to treat side effects that have developed for weeks.
So, Dr. Marron, you were talking about the PD-1, PD-L1 axis for immunotherapy. Are there any other type of immunotherapies that are available for cancer patients, specifically lung cancer patients?
So first of all, I'll say that the classic therapies that we've been using in cancer for many years, which are both chemotherapy and radiation, themselves, you could argue, are immunotherapies. They do, especially when they're combined in the right ways, they can activate the immune system to recognize and attack cancer. And we're running many trials here at Mount Sinai, including trials that have been supported by the Cancer Research Institute, looking at the combination of radiation and immunotherapy to get even more bang for your buck. So have even a greater response and a more durable response to immunotherapy. There are other therapies that are FDA approved that are immunotherapies. So along with drugs targeting the PD-1 and PD-L1 axis, there are drugs that target CTLA-4. There are 2 FDA approved drugs that we use in lung cancer that target that other off sign, or it's another stop sign, you could say. And sometimes in a subset of patients, we really see a nice responses when you combine drugs that block both PD-1 and also CTLA-4. And there's also many clinical trials looking at dozens of other stop signs. I'll say there's one stop sign, which is called LAG3, where there is an FDA-approved medicine in the treatment of melanoma. And we have lots of clinical trials that are ongoing here at Sinai and elsewhere, looking at antibodies targeting LAG3 in patients with lung cancer to see if that can further improve outcomes. And there is a lot of other data targeting other stop signs like TIGIT and TIM3 and many other on and off signals within the immune system. And I'd say, the CRI report that they put out every year shows that there's nearly 5,000 different agents in development targeting all sorts of different on and off signals in the immune system. And I think there's a lot of promise for the next 5 to 10 years of identifying other ways in which we can improve the outcomes in these lung cancer patients.
That's really interesting, and that's really promising for all the patients that are suffering from this deadly disease. I would like to take one step back and just ask about, we have been hearing this, that immunotherapy is not a one size that fits all. So is there a criteria that we need to see for screening the patients, who is eligible, who is not eligible?
Yeah, so immunotherapy doesn't work for everyone. One of the first things that we do when we're diagnosing somebody with non-small cell lung cancer, especially if they have metastatic lung cancer, is we first want to do mutational analysis to make sure that they don't have any common mutations that we see that we can target with oral medicines, what we call targeted therapies. The majority of patients, unfortunately, don't have those mutations. And so the next thing that we do is we make sure that we have a biopsy of the tumor, and we can look at it under the microscope for something called PD-L1, the stop sign that we were just talking about that is targeted by some of these immunotherapies. And based on how much PD-L1, how many of these stop signs you have on your tumor, that oftentimes is going to help us decide on what is the optimal therapeutic approach for patients. So there are some patients where we can get away with just giving them a single immunotherapy and no chemotherapy. There's other patients which is probably the most common situation, where we give a combination of chemotherapy and immunotherapy. And there's another subset of patients where I oftentimes will not give chemotherapy, but I'll give 2 different immunotherapies targeting both PD-1 and the CTLA-4 pathway, the other stop sign. So there's many different treatment algorithms. Every patient is completely different, and everybody's cancer is completely different. And so we really have to, have a discussion with patients about risks and benefits of different therapeutic approaches and the likelihood of different therapies working for one patient versus the other. But it is important to note that, everybody's cancer is completely different. Everybody's immune system is completely different. Mm-hmm. And so the way in which patients respond to cancer is different from one patient to the next as far as time course, depth of response, and if the cancer ends up coming back. Mm-hmm. And so it's important to set expectations realistic early on. And unfortunately, most patients either don't respond to immunotherapy or they do, and then eventually their cancer progresses. And we have, radically changed the way in which we treat lung cancer in 2023 compared to in 2013. 2013, or even after that, probably within the last 5 years is when we've seen the greatest changes. And, for patients who have metastatic lung cancer in 2023, they're living more than twice as long as they lived 10 years ago, and we just had chemotherapy. So it really is a game changer. However, while we in the past never really cured lung cancer with chemotherapy, now we are curing what was previously incurable lung cancer, but only probably in 15 to 20% of patients using immunotherapy. So we still have a lot of room to grow, and we have a lot of work to do in the clinical trials and also in the preclinical research that we're doing here.
So, Dr. Marron, what are the resources that are available for patients who are actually seeking out for immunotherapy? Are there any, can you direct them to any specific organization? Can you direct or any links that they can follow to see what immunotherapies are available?
So there's many different patient support groups. I know the Cancer Research Institute has a really good clinical trial finder that can be used and can be found on their website. And I think that one of the most important things is that patients reach out and they identify a lung cancer expert. Oftentimes these are found at academic institutions, but you really want to identify a oncologist that focuses on lung cancer. And even if that means that you're going to see them occasionally and you'll get your treatment closer to home, especially for patients living in more rural parts of the United States or elsewhere around the world, I think it's always good to have the input of a patient or of a physician who really treats lung cancer all the time, so they know, the cutting edge advances. Because even in the last year, there's been huge leaps and bounds of improvements in the ways in which we treat lung cancer, and the trials that are going to read out in the coming years are really going to be game changers. And you want to make sure that you have someone who's on top of all the data so that you're getting the best care possible.
Dr. Marron, you are the director of the early phase clinical trial unit here at the Mount Sinai. So what are the new advances that we can see in clinical trials? What is something that is in the pipeline that we can look forward for?
So I'll tell you, at Mount Sinai, we have a phase 1 program where we're looking at lots of new therapeutic approaches, really across tumor types, but I'm particularly focused on lung cancer, where we're looking at new approaches that have been identified in the laboratory to harnessing the immune system even better than the drugs that we already have in order to get the immune system to recognize and attack cancer as it's supposed to be doing. There's many promising agents that are not only focused on better activation of the T cells, which are the killer cells that we commonly think of responding to these immune therapies. Many people have heard about T cells in the context of HIV, but T cells are extremely important not only at protecting us from infection, but also at protecting us from cancer. So the therapies we have right now are really targeted towards those T cells. But interestingly, what a lot of people don't realize is the complexity within the immune system. It's not just one or two different types of cells doing, the same sort of thing. You have dozens of different types of cells within the immune system. And if you cut out a lung tumor and you look at it under a microscope, which is something we do here regularly in the laboratory, one of the things that we realize is that the majority of the cells in some patients' tumors are actually immune cells. And even in patients where most of the cells are tumor, there's still lots of immune cells, oftentimes billions of immune cells within the tumor. And there's lots of different types of immune cells. Some of them are trying to recognize and kill the cancer. Some of them might be recognizing your COVID vaccine or your flu vaccine from last year. But the most common immune cell within the tumor is actually something called the macrophage. So the macrophage is, I always refer to it as the janitor of the immune system, but that doesn't give it enough credit because it actually is a very important cell in teaching the immune system what to recognize and what not to recognize. But what happens is that a lot of cancers will recruit these janitor cells, these macrophages, and they sort of turn them against us. They hijack our immune system and they get those macrophages to really turn off the immune system. So they keep your T cells from killing cancer cells. They basically develop this whole environment in your lung tumor and wherever else the cancer might have gone that really promotes tumor growth and does not promote your immune system from attacking the cancer. So a lot of the work that we've been doing here in the laboratory at Mount Sinai is better understanding those macrophages and those cells that are related to them, like dendritic cells, which are kind of the professor cells of the immune system, so we can better get them to do their job and really disrupt their ability to turn off the immune system. And we have some very exciting research that's being published this month during Lung Cancer Awareness Month, very actually, fortunately, in Nature, which demonstrates the way in which lung tumors are really able to harness these macrophages to turn off the immune system. And it really, for the first time, is describing how that happens, how your lung tumor is actually teaching your bone marrow and your immune cells elsewhere in your body to come to the tumor and differentiate into these bad guys, these bad macrophages, and really suppress the immune system. And we had made these discoveries because we had been looking at lung cancers that were being cut out in the operating room, and we quickly would run them over here to the laboratory and do a deep dive, really looking at every single individual immune cell within those tumors so we could better understand how to harness those immune system cells to help not only patients undergoing surgery, but also with metastatic disease. And one of the interesting things that we noticed when we were looking at these immune cells is that the immune cells had a very similar phenotype or sort of functional personality to the immune cells that we were seeing in allergic conditions. So we were seeing very similar results looking at our lung cancer lesions that our colleagues in dermatology were seeing looking at eczema. And when we compared these lung cancer lesions to eczema and also other allergic conditions like asthma, we realized that the same sort of pathways hijacking the immune system were taking place in eczema lesions as in lung cancer lesions. So there's part of your immune system which is called the type 2 part of your immune system, which is sort of, I often refer to it as a vestigial part of your immune system, or leftover from back in the day when we lived in the woods and we were exposed to lots of parasites and worms. And this type 2 immune system now, because we are not being exposed to that, or at least is the cornerstone of what we call the hygiene hypothesis, is that's one of the reasons why kids nowadays are having food allergies and we can't have bake sales at school the way that we did when we were young. And all this sort of activation of the type 2 immune system is allowing these, allergic conditions like eczema and food allergy and asthma to really take over, especially in a younger population. So those physical conditions are being treated very well with a variety of allergy medications now. And there's some biologic immunotherapies that are also being used to treat those conditions, that many of which have been developed here at Mount Sinai. And they're very successful, and they're actually very non-toxic, which is always appealing, especially when you're thinking about using them in children. So we were seeing the same sort of allergic fingerprint, if you will, in lung cancer that we were seeing in asthma and eczema. So we decided, well, why don't we, try preclinically, so in mouse models, to see if we can use the same sort of immunotherapies that are being used for eczema and treat lung cancer. So in a mouse model of lung cancer, specifically a lung cancer that looks like a smoking-related lung cancer, which is called the KP model, we treated that model with normal immunotherapy. Doesn't actually work very well in that mouse model because the tumors kind of hijack the immune system and turn the immune system off. But the allergy medicine, which neutralizes a cytokine called IL-4, which is very commonly seen in patients with bad allergies, when we got rid of IL-4, all of a sudden the tumors were not growing very well. And when we combined it with the immunotherapy, with the standard cancer immunotherapy, so we were combining allergy immunotherapy and cancer immunotherapy, when we put them together, the cancers grew even slower. So we saw this as being very promising. We decided to explore this in human patients because, like I said, most of our patients are receiving immunotherapy, but then it either doesn't work up front or it stops working eventually because the cancer is somehow outsmarting us. So we opened a clinical trial in which we enrolled patients that had lung cancer and they had received immunotherapy, and most of them had responded well to immunotherapy, but then their cancer started to grow. And all we did was we continued that immunotherapy and we added on 3 treatments with a medication called dupilumab, which blocks both IL-4 and IL-13, which are 2 kind of classic parts of the immune system that cause allergies. And dupilumab is FDA approved for lots of different indications like eczema and asthma, and we know that it's very safe, and so we felt comfortable trying it in our patients. And so we opened this clinical trial. We consented initially 6 patients as part of our first run-in just to make sure it was safe, as we thought it would be. And nicely, we saw that it was a safe combination. And actually, half the patients had either stable disease, meaning their disease didn't grow after those first 9 weeks, and one patient actually had a significant reduction of almost 40% after just 2 months of adding the allergy immunotherapy to their cancer immunotherapy. And that patient, actually, we just continued his cancer immunotherapy that previously had not been working after we gave him those 3 doses of the allergy therapy. And he's now alive and doing well, and his cancer is almost undetectable 500 plus days out. So we're seeing some very promising signals there. I will always warn patients that this is a very small study. We are continuing this study. It's a larger study now. And we actually, thanks to the Cancer Research Institute, are now opening a earlier phase study where we're treating patients with stage 1 lung cancer with this same combination, just giving them 1 dose of cancer immunotherapy and 1 dose of allergy immunotherapy prior to surgery. Because we know that even in patients who have stage 1 cancer, there's a good 35% chance that that cancer is going to come back, and at which time it's probably going to be metastatic and incurable. And so we want to further increase the likelihood that surgery is going to cure those early stage patients. And that grant is also going to help us better study these tumor lesions so we can better understand who's going to benefit from this sort of therapy and who won't. Because like I said, half the patients, their cancer kept growing. And I don't think that this is going to be the be-all and end-all cure, but I do think that it's very promising. And I think that there's a lot of exciting, promising agents that we have open in our early phase trials unit and that are open at many of the other academic institutions running clinical trials of novel immunotherapies. And I think that in the coming decade, we're going to be moving more towards a personalized approach, where when patients are first diagnosed with lung cancer, we're going to be able to do a biopsy of their tumor, and or eventually, hopefully, we can just do a biopsy by taking some blood and testing their blood for sort of evidence of their cancer. And we can identify the optimal immunotherapy to give a patient so that we give the patients the best drugs without giving patients drugs that aren't going to help them and just give them side effects. So I think that there's a lot of room for growth, but I think there's a lot of exciting potential novel immunotherapies that are on the near horizon.
That's really, really heartening to listen to, and that's really impressive. All the work that you have been doing with all the clinical trials and such fascinating discoveries, which are just completely out of the box for common people like me. We would not even think that allergy medicine can be used to treat cancer, but that's phenomenal. And I want to congratulate you and thank you so much for all your time and giving us such a nice introduction into the lung cancer and the cancer immunotherapy.
My pleasure. Thank you.